Hi. So here we are. Oops. Ted. Thank you. Sorry about that. Yeah, continuing the assessment of the newborn. Obviously, newborn, placenta still in the room. So, same approach as the pediatric. We do the hands off, end of bed, confirm that there's no airway problems, breathing, they don't look too bad. Then we're going to correct any ABC issues. And then we're going to move on to the pediatric triangle. So, with pediatric triangle, we have work of breathing, circulation to skin, and appearance in the form of tickles. So, that's tone, interaction, consolability, look slash gaze, and speech slash cry. Right, after that, ensure there's no ABCDE issues. It's all right at this stage to go and touch, take a pulse, check how the pediatric actually is. And then general history taking. So in this circumstance, the history taking is quite simple. You don't have to go into a whole load of history taking in terms of the social history, family history, anything like that. We've got a brand new baby here, so probably a read over the notes, the maternal notes would be quite good, and then just a general history of what's happening. So the history of presenting complaint, so to speak. So ask the people on scene, what's the problem? Why have you called? If they haven't called, if it's just a regular delivery, then the questions that you'll be asking is how long have you been in labour? Any problems during your pregnancy? Any ongoing illness? Any developments with the baby? Anything that has been brought up in the prenatal notes? So it's not a huge structured history take for the brand new born baby. So let's go on and assess the baby. Now the baby's out and they do not need resuscitation. Let's just give him a general check over. All right. So first thing we're going to do is to check the color, the tone, the heart rate, and the rest rate. These are the basic obs that we need for a newborn baby. So looking at the color of the baby, if you haven't had to perform resus, if they're crying, etc., they should be pink. I mean, they're covered in gunk, but essentially once you take the juices off of them, they should be a pink baby. A baby that is white or blue or grey is not a healthy baby. Okay, so checking on the colour. Again, as we know with little newborns who aren't white, we check colour in the mucosa, in the lips, in the fingernails. We're checking to see if there's any cyanosis there. Next, we're checking the tongue. So that is baby crying, kicking, that kind of thing. Are the arms moving? If you were to pick baby up, does it kind of flinch or whatever, move around? Or is it just still, lifeless? So you can see here, we're looking at very much extremes, either well baby or not well baby. So colour, normal, or colour, not normal. Tone, okay, Teddy. Sorry. Tone, normal tone, or floppy. Heart rate. So get your steth out here. Turn it around to the bell end. If you can't do that, if you can't hear it through that, you can use the normal diaphragm, but just be careful because you'll get a lot of breath sounds in that as well. So it is best to turn it around and use the smaller end. Right in the center of the chest, or as we know where the apex beat is, we can go just a little bit down on the left-hand side. So we're expecting the newborn baby to have a heart rate of around about 150. You can check this up and use it as a resource. Check with different websites, different authors. What do they think the range is for a newborn baby? So we're looking at, is it around about 150? If it's less than 100, I think you need to take it a little bit longer. It's really hard to count this. So count it over a full minute if you're thinking, I'm not really sure what it is. If it's less than 100, you'll know about it because it's slower than it should be. Again, you can get your metronome on your app if you want to measure it in comparison to that, to go, whoa, that's way faster, or whoa, that's way slower. Remember the magic number of 60. If the heart rate is less than 60, they need CPR. Check the rest rate. You can watch the rise and fall of the chest. So we need to know whether baby's got a normal respirate or a high respirate or a low respirate. So we're going to come on to this in a moment. I'll show you a table which I would expect you to fill in. But the overall view of assessment of the newborn is a very brief history take, immediate assessment. Then you're going to go on and make sure the baby is absolutely warm if you haven't done so already. Then you're going to do an APGAR assessment, and then you're going to check for red flags. Simple. Okay? Right. So moving on to the immediate assessment, what we've just discussed. As I said initially, we're looking at whether the baby is healthy or whether it's ill. So here we look at the tone. Is it normal, good tone, or floppy baby? Color, whether the healthy neonate comes out a little bit blue, but there it says should be pinkish within the 90 seconds. So a minute and a half to pink up. That's just what it takes to get the oxygen in and get the gas exchange taking place and for the baby to be fully oxygenated. If the baby's pale, cyanosed, grey, we're thinking this is a really ill baby. We do not want to see that. So heart rate, I've called it 150, but here we have 120 to 150. That's why I said double check your resources. So some resources might say 120, some might say 150. And again, if it's really, really slow, you might need to start CPR. Respiratory rate, yes, they're going to cry, hopefully within a few seconds. If they don't, you might have to do the drying of the baby. And if they still don't cry, then you might have to go into your resus again. But should be a little bit of a cry and then carry on breathing. So some of them don't cry very much at all. That's not a cause for concern, but normally, initially, they'll do at least one type of shriek, one type of cry, because they're out of the womb. And that's how they take their breath in. But after that, if they just go to normal breathing, just count the rise and fall of the chest. See whether you think it's in the normal range or not. Obviously, if the baby's not breathing, we need to do something about it. Right. This is what I was talking about before, going crazy about making sure that the baby is warm. So this is, that's kind of what it looks like. A little bit of blood, maybe a bit of mum's poo, maybe a bit of their own meconium, but they're covered in this. They've come from the warm into the cold. So first thing I need you to do is close the windows, warm the room. And I'm not exaggerating here. We want it to be warm as it is inside the womb. Dry the baby. So you should definitely have 2 towels. If you don't, if for some reason in your maternity kit it's only got 1 or none, get that family, get me some towels, dishcloths, anything at all. So you want something dry, first of all. This is what you're going to rub the baby with. You're going to have a dry towel, hopefully. Completely rub all over. Mind the head, because it's still got its soft fontanelle. Mind the neck. The baby's head is going to be really heavy, so therefore there's no tone yet in the neck, so the baby's really like that kind of a head. So always supporting the head and the neck. Dry. Best to put them down on a surface, maybe the bed, so long as there's no urine, no poo, no sweat, no water, no blood. It has to be a clean, dry, warm surface. So dry all over. It might take you a couple of minutes to do this. Like I said in the previous PowerPoint, this has once to me been the wake-up call the baby needed. This was my resuscitation of that baby. A really quite vigorous dry can bring the baby back to life. Anyway, once you've dried, you make sure all of that stuff is off of them. Get rid of that towel. What I do not ever want to hear about is somebody wrapping the baby up in that towel. Now, people think it's appropriate to do that if they open the maternity pack and there's only 1 towel in there. If I ever hear of that, I'd be like looking for your registration back. This is totally wrong. That is going to hypothermic the baby. So new towel, nice and warm, nice and dry. Wrap them up in it. Okay, not just like us, a little bit around the top, have the feet hanging out. No, you want to swaddle them. So wrap them all up nice and neat and warm in there. Get something on their head. So if you don't have the little hat inside the maternity case, which you should have, then you're going to have to fashion something out of the towel, or see what the parents have in terms of gifts or whatever. They want something on their head because a third of their body heat is lost through their head. So we're drying them, chucking the towel, getting a new towel, wrapping them up nicely, popping the hat in. Yeah, the hat is not for cuteness. It's not for your selfie. It's for the baby. Okay, so bear that in mind. Next, you're going to do an ABGAR score. Now, an ABGAR score is world known. It's something that midwives will do, hospitals will do, and something that you'll be asked on handover if you have to bring the baby into the maternity ward. So please know this. If you don't know this, you're going to look like a fool because everyone knows ABGAR. ABGAR stands for appearance, pulse, grimace, activity, and respiration. And this is the standard assessment of the neonate at birth. So for each of these sections here, so let's go to appearance, you have to score the baby. So a normal baby that comes out of the womb and cries and you've dried it and it's looking lovely and it's great, it's going to be named after you, life is fantastic, that's going to get 2 points because it's pink. The terrible situation where they're cyanosed or pale all over or grey is getting 0 points. So I'm sure you can see where this is going. The middle ground is peripheral cyanosis, which you will see quite often. Hopefully that will go away within that 1.5 minutes to 2 minutes. But if it doesn't, you're only giving them 1 point. Pulse rate, we're checking here. So as you can see, normal 100 to 140 in this chart. Grimace. So that means when you could do this when you're drying the baby as well. So you're going to put some type of stimulation onto the baby. This doesn't mean that you're going to do like the trapezius squeeze or anything like that. Whatever you can do that's going to make the baby react. So something quite gentle like the towel rub. You might have to move on to the trapezius squeeze. Sometimes a little tickle of the foot. Anything to get them to move. So if they cry or move or anything like that, that is great. That's getting you 2 points. But if they're just screwing up their face, they're not associating where you've presented this kind of stimulus, that's 1 point. It reminds me a bit of GCS. You know, when you do the motor response on GCS, whether they localize in pain, whether they know where the pain is, or whether it's just a general, ow, that hurts. The tone, which is called activity, in ABGAR, floppy, normal, and then in between, some type of flexion. So you might have this on one side, you might have it that there's a little bit of movement, but not completely pulling and moving as normal. And then the respiration level. So nice strong cry when they come out, whether the breathing is slow and irregular or whether it's apneic. So the other baby that I resuscitated after birth, that was a baby that probably would have scored 1 point there, 2 points there, no points there. Can't remember whether it be 0 or 1 there, but it was definitely an apneic baby. So that baby actually came round with oxygen. Would you believe it? And right in the middle of the resus, well, not the middle, the start of the resus, we've done all the drying, we've done the inflation breaths, we checked the pulse, and the pulse was okay, but the baby wasn't breathing. So it was actually connect up to the oxygen, do my 30 seconds, and that thankfully saved that baby. So anyway, everything of this is important. It's not just an exercise to fill out a table. Do an ABGAR score, score them. So you have to do this immediately after birth. So that's 1 minute. So straight away, of course, the mum wants to hold the baby. The other person wants to cut the cord. Someone wants to take a selfie. Everyone wants an awe moment, but you've got work to do. So make sure that you're cleaning off the baby or your first assessment, whatever, takes you to around about a minute because you're going to have to do an ABGAR score in 1 minute. Then you're going to do another ABGAR score 5 minutes. So you're going to be able to compare them. Is the baby improving? Is the baby deteriorating? Hopefully you're going to have a full 10 points and that's going to be a really lovely, happy baby. Then you can give it to the mother. Mother will put it to breast and hopefully baby will start to feed. That's all in the nice world, which does happen a lot. Most of the time, I think I've been to, I think it's around about 14, 15 births. And most of the time, it's really, really straightforward. You just feel like a bit of a div standing there wiping up things, just in case. Anyway, recap on ABCAR score. This is what it stands for. 0 points for bad, 2 points for good, 1 point for in between. Do it at 1 minute, do it at 5 minutes. Write them both down on your PCR or your PRF. If the midwife is there, do it with the midwife. Write down, this is the score we got, this is the score the midwife got. If there's any discrepancies, talk it through with the midwife. Don't forget, they are the knowledgeable ones. They're the ones that do this for a living, so we can learn from them. As a side note, please write the midwife's name on your PCR, your PRF. That's really important to do if they're present. So write midwife present and take their name down. All right, so we've done a very brief history. We have done an initial assessment. We have made sure the baby's warm, and now we have done the APGAR. So all that's left to do is to check the red flags, hopefully, she says. Okay, what I've done here is I've put some videos on for you. So once you look at the static PowerPoint, you will see a short video that lets you score a child on the ABGAR scale. It's all very fine. There's a lot of talking. It's quite nice. And then this second video is not nice. So this video could be upsetting for you if you have some type of experience that you don't want to relive. Don't watch this video. This is of a very ill child. For those of you that can watch it, I would just advise you watch it, pause it every now and again, and do the ABGAR score. Do it for yourself. All right, so red flags. First one is meconium. Now, meconium is poo. It's the baby's first poo. So that normally happens about within the first 24 hours. And that's not a red flag if it's happening in the first 24 hours. It's natural. It's a normal thing to do. The red flag with meconium is the aspiration, i.e. if it happens in the birth canal. So just to recap, normal meconium is all right. You can see it actually up to 72 hours, but the normal time that you will see meconium is in the first 24 hours. It can look this nice greeny colour, quite normal, or it can be a bit black. Okay, so don't be alarmed if you see strange colour poo. That's okay. Now, if you see the strange colour poo around the nostrils, around the mouth, then you got to be worried. Take that child into hospital because it's more than likely that they have aspirated. Aspirated means that they have swallowed or sucked, I should say, this into their lungs. That's not good. That's not going to let the lungs be able to expand and contrast properly. This baby will have breathing problems if they have aspirated. So meconium aspiration syndrome is red flag. So if you have got a child with any sign of meconium staining, I want that child brought into hospital. All right, you can explain to the parents the risk of getting it in the lungs. So if you want to know generally what it looks like, you can watch this video. I had to put this little bit in because the guy basically just sticks a tube down, and we don't intubate like that. We have forceps and things like that, but it's an emergency situation. So you'll see a baby that has that has meconium aspiration. This video here is, that's another upsetting video, and I think, no, that's in a different, no, sorry, that's further along. Fine to watch. These videos are fine to watch. All right, so we've learned about meconium. Next red flag. Sepsis. Okay, so this is the other sad video that I was thinking about. So that's a death that comes from sepsis, just from a medical professional not knowing the signs of sepsis and missing it. Now, you're probably feeling that this has literally been banged and drummed into your head right now. Good. I'm glad you feel like that. You have to know sepsis, especially in children. We can stop it. If we recognize it, we can get them into hospital. They can get IV fluids, they can get IV paracetamol, they can get antibiotics, and they can be fixed and healed. Sepsis, without us recognizing the signs, well, I was going to say will, but not necessarily. It could definitely lead to death. So please, please, please be aware. So sepsis, as you guys now know after doing the pediatric, is not just about OBS. It's not just about the stuff that we look for in an adult. Oh yeah, they got a high temperature. Oh yeah, of course, look, their heart rate's up, their respirate's rate's up. Sepsis blew them in. No, we're looking at all the different signs in the newborn. So it's the same as a neonate, it's the same as a small pediatric. We're looking at all of the same signs. Now, you won't see a lot of them in the newborn, so you have to be wide awake and alert to the ones that you can detect. Respiratory distress, grunting noises, lethargy, floppiness, irritability, don't stop crying, hypothermia, hypoglycemia, no tone, acidosis, no breathing or stopping breathing for a period of time, cyanotic spells where the peripherals or central goes a little bit blue, poor perfusion. So that's what we're looking at in the neonatal and the newborn. Please trust yourself if you see any of these. And if you're thinking hypoglycemia, what? It's all right to check, especially if the mother has gone through gestational diabetes. It's all right to check blood glucose on a newborn. Yes, it's going to cry. It's going to make that poor little kid cry. But if there's any reason to suspect it, then you should be checking it. Hypothermia, most of the time our tympanics don't fit in children, so you're going to have to go with the general feel. If the midwife's there with you, the midwife will have all of the tools for checking the child's temperature, SATs, pulse properly. But the signs that we're going to see are the respiratory ones and the appearance ones. So you should notice newborn sepsis, your pediatric triangle, and in your ABGAR score. And in fact, even just the general assessment, you should be noticing this. If you miss this, then it's a bad day. The next red flag is dehydration. So again, repeating things from the pediatric sessions that you've done. So this sunken fontanelle, that's going to be a lot more prominent for the newborn. So we know the fontanelle is definitely not fused when they've just been born. So if you see it depressed, sunken in, that's a sure sign of dehydration. Sunken eyes, dry tears. This not so much so because you won't know that yet. The urine output you won't know yet either. Breathing, yes, you can detect that, and heart rate, the irritability, the floppiness, the skin turgor. You can detect these things, and you can detect these things. Why would a baby be dehydrated? Is that actually possible? They're in their first seconds of life. What makes you think that they could be dehydrated? Well, again, if the mother's dehydrated, that will be reflected in the newborn as well. So if the mother's gone through any type of infection, low blood pressure, if she's had a massive bleed prenatally, that's going to affect the newborn as well. So anything that could cause the mother to be dehydrated can have its effect on the child as well. So please bear that in mind. Okay, safeguarding. This is really difficult because it's a newborn. If it's born at home, then the parents are going to be a little bit edgy anyway. If it's born unexpectedly, the parents are going to be edgy. It's a really nerve-wracking time. They've waited all their life, or the very least a few months, for this thing to happen, and they're going to be really worked up about it. So please don't confuse anxiety and heightened emotions with suspicious behavior. When it comes to safeguarding the newborn, I want you to have it in the back of your mind. You're not going to be doing it very often, but you need to be thinking about it. So if you've got a midwife there with you, that's the person you tell your concerns to. Even if they're in the room and you think, well, this is going to be really obvious, don't keep it to yourself. Tell the midwife. If there is no midwife with you, try and get that child to hospital. What my midwife colleagues have told me that is generally accepted is to say, oh, need to take the baby to hospital. She is a little bit cold. And then that's it's not necessarily a code, but that's the excuse that they give just to say, right, we're bringing this newborn in and we're going to pass our concerns on to the appropriate people. You will find that sometimes newborns are already known to the social care system, even in utero. And that's because of the conditions of the mother who's carrying the baby. So it might be that it flashes up on your MDT that says this baby is known to social services. And in that case, you'll probably have to phone up the clinical hub and find out a little bit more information. It should be that there's a midwife on scene, but if for any reason there isn't, then this baby needs to be conveyed, because you cannot leave the baby who's already got a flag on it at home with the people who potentially could be those that you need to protect it from. So look out for that. Anyway, general things to think about when you're thinking about safeguarding. The atmosphere in the room at birth. Is everyone super, super, super tense? Is there a kind of a chilling atmosphere? You can get vibes from the room. Is this baby really welcome? Are people happy to see it? Or already within the first few seconds of its life, is it not wanted? Just think about those kind of things. Now, this next point sounds a little bit wrong, but it's historical data. So I've written it in here, although I felt a bit weird doing that. But my midwife colleagues have told me that we should be aware of the men in the room, especially if they're not the baby's father. Especially as well, they said if there's any mental health issues with the men. Now, I didn't write that down because that felt a little bit step too far, but I want you to be thinking about this. The reason being is because those babies that have unfortunately been injured or worse through safeguarding or through actions that we could possibly prevent, it has been proven that most of those are to do with men who are present at the birth. So that's not me saying that, and I don't have a reference for you at this stage. This is what the midwives have told me. I am waiting for some more information. So I've put it down there for you to think about, but for you not necessarily to write down in your paperwork, there was a man in the room when the baby was born. Okay, so don't get too carried away with it. When the baby's born, check out the other kids. What do they look like? Do they look scared? Do they look like terrified for this little one coming into their lives? Are they quiet, withdrawn, staying in the corner? Are they behaving in any way strangely? This is really difficult because emotions aren't normal during a birth. But all I want you to do is keep it in mind. And if you're suspicious, either take the baby to hospital or find a reason to talk to the midwife outside of the room and report your concerns. Okay, so a summary for you. When you go to any delivery, make sure that you know the Resus Council guidelines algorithm for resuscitating a newborn. Understand the reasons why newborns might not make it in terms of hypoxia, illness, and their development issues. Know what you're doing and why you're doing it. So when it comes to inflation breaths, when it comes to ventilation breaths, know how many you're doing, why you only do that amount, why do you resus if the pulse is less than 60. Know your APGAR score, 1 minute, 5 minute. And if you're there for longer, you're supposed to do it every 5 minutes after that. So on 10 minutes, 15 minutes, etc. So constantly count up your APGAR scores. If they're differing, that would be a bit of a red flag. Not if they're improving and they come to 10 points, that's okay. But if they start off at 10 and then they fluctuate a little bit, you need to keep doing it. Remember the red flags: meconium, sepsis, dehydration as well. And keep in mind safeguarding concerns. Hopefully for you guys, this would be a really special moment whenever you get to deliver the baby. My first one, I was pathetic. As soon as I got to hospital, I cried. And then I phoned everyone, was like, I've just delivered a baby. So I can remember the first time I did it. I can remember the ones that went wrong. I can hardly remember the ones that went right. But I remember the feeling, and it is really nice. And I hope you do get to witness a special moment soon. All right, hope you've enjoyed this. Bye bye.